Welcome back, everyone. We'll start with our next session, session 9, which is quality of life and palliative care issues. I would like to welcome the chairpersons for this session, Dr. Manisha Dwivedi, Dr. Nitin Pai, Dr. Prashant Butch, Dr. Virendra Singh, and Dr. Bhagwan Singh Thakur. I request the chairpersons to please announce the speakers.
So, thank you very much. We are thankful to the organizers of this conference. And the first speaker is Dr. Sambat, and he'll be speaking on the newly diagnosed decompensated cirrhosis in geriatrics, the unique issues and solutions. Dr. Sambat, please.
Thank you. First of all, I'd like to thank the organizing committee that inviting me to join this beautiful countries and the very well meeting. So I will start with my topic today as shown for 15 minutes. So my objective as shown here and have nothing to declare. So I would like to start with this summary table to show some standard of care for diagnosis and classify, categorize the case of cirrhosis. As shown, the first step is to confirm cirrhosis with clinical sign and identify the cause of that. The second one is to determine severity of fibrosis, which means that this one is quite a current useful tool. You can use both non-invasive tests. FIB4 is the most popular one, and liver stiffness measurement is the most commonly used worldwide right now. And especially in those cases that we talk about is advanced age or elderly cases of cirrhosis. This is the useful tool because it's less invasive. When you get the diagnosis of cirrhosis, you can categorize them into moderate to high risk or lower risk. Again, I would like to emphasize that the cutoff of FIB4 criteria for classify those with older or elderly cases, you have to use the different thresholds, such as more than 2. And the above cutoff point for high risk group, normally we use 3.2, but in elderly age over 70, you can use above 4, something like that. This is the nice summary to show you that the most common complication in decompensated cirrhosis on the right-hand side is including esophageal varices bleeding, ascites, and hepatic encephalopathies. All of them bring about the short or medium survival, as shown here. So, how frequency of the elderly cases present with cirrhosis? From our database of AARC led by Professor Sarin, I use this database to categorize those with age above 75 and 80. As you can see, the preference is about 0.3 to 0.8%. It's quite low. But interestingly, from this table, if we compare those with age over 75 to those with younger age group, as you can see, the complication, including the liver-related complication within 30 days, is quite higher, about 2 times in those with elderly cirrhosis. But the 30 days mortality rate is the same. For the factor associated with death in the elderly, as you can see, 2 organ failure, including renal failure and respiratory failure, is the hallmark that you have to notice in this database. So what is the key issue to address? I will bring you to the 5 following issues. The first one is the management of complication, including ascites, encephalopathy, and variceal bleeding. So most of these complications have to use some medication. In summary, you have to be careful or be aware of the side effect of medication that you use for those 3 complications. For the first one, this is the nice review article led by Professor Kamath. As you can see, the GI bleeding in elderly cirrhosis you may be reluctant to do endoscopy or not. But from this review, we emphasize on the issue that diagnostic EGD is quite safe in elderly patients, but you have to be aware about the dose of sedative medications and all the comorbidity that may bring about the complication during the procedure, especially the respiratory suppression. For medication, including non-selective beta blocker in elderly, as you know, the side effect of hypotension is very common. So you have to start at the lower dose. And vasoconstrictive agent that you use in acute variceal bleeding, you have to be aware of side effects, especially cardiovascular events. For tips, in case that not respond very well to the ECD and variceal bleeding control, you may be considered, but the data of this group is vary widely, depend on your center. Some can support, some may not, especially those with age above 70 years old. This is the table to summarize the action of two popular beta blockers that currently used. Cannabidiol is the emerging medication that show promising data on, especially on primary prevention of esophageal variceal bleeding. So this is the thing that you have to keep in mind. It can lower blood pressure, the systemic blood pressure around 10 millimeter mercury. So be aware of normal dose if you use. So we suggest you to use lower dose, such as start with 6.25 milligram initially, and then step up every 3 to 5 days. This is a normal dose in general population, so I recommend to start with the lower dose first until everything clear, no symptom of collapse or fail, so you can increase the dosage. This is the summary that the primary prevention, especially in those with cirrhosis, is the area to use cannabidiol. But keep in mind that all of the study that summarized here is not include those cases of cirrhosis with advanced age. For contraindication to use, as I mentioned, you have to be aware of those cirrhosis elderly cases with hypotension, AKI, or have moderate to severe ascites. If the complication occur or window period, you should stop the medication for a while. The next one is nutritional support and frailty and function status. So both of issues are very important in those elderly patients. Why? As you can see from this study, this is cohort study from Italy. Look on the column of cirrhosis. You can see that those cirrhosis have sarcopenia preference is quite high, about 62%, and all of them confirmed is around 14%. There's another term that nowadays quite commonly used is dynapenia. Dynapenia is a term of loss of muscle strength, while sarcopenia is a combination of loss of muscle mass plus strength. So you can see that older cases have both conditions, sarcopenia and dynapenia. Focusing on the correlation between the things that we found, as you can see on the yellow column, you can see that the muscle mass show no correlation with minimal nutritional assessment score. But if you see the clinical implication, the higher risk of complications such as fall, fracture, and mortality rate is increasing in those with cirrhosis, especially those with advanced age. So what we can do? The current three major guidelines of cirrhosis, especially focused on nutritional treatment, are recommended both in ESO, SPEN, and ASLD. So the optimal calorie intake is about 35 kilocalories per kilo. And as a APASL guideline, recently summary in 2023, we also emphasize on nutritional support with evidence base of 1A. And we emphasize on hepatoprotective treatment and reduce the infection risk and promote recovery in patients with ESLD. That's the key from our APASL guideline. For protein intake, you have to use about 1.2 to 1.5 gram per kilo protein per day. And for the frequencies of meal, we emphasize on add the meal in early morning or evening snack. So it's about 3 to 5 meals per day. Regarding to the branched-chain amino acid supplementations, there's a different opinion between 2 and 3 guidelines. The first 2 guidelines ISO and ESPEN support to use especially those with decompensated cirrhosis or those with protein intolerance. But in ASLD, it's not recommended beyond emphasizing the importance of meeting daily overall protein target from diverse range of protein source. That's the thing that you have to consider by yourself. The next 2 consideration is about the polypharmacy and drug sensitivity. As you know, with advanced age, they are compromised and cannot tolerate well with the adverse event or side effect of the medication, especially those with commonly used medications such as pain control pill and sedative medication, may affect to your liver and kidney function. And last but not least is the palliative care and goal of care discussion. This is quite important, but I think you may get for further detail in the next session of talk I see in the schedule, which is quite important to talk to the family and caregiver. I show you some side effects of diuretic, the most commonly used in cirrhosis, especially in elderly cases. This is the cohort 20 years ago in United States. As you can see from 180 cases, the dose of diuretics is the standard dose in most of them. And you can see that the odds ratio to develop hyponatremia was about 3 times higher for female than male. And it usually occurs in the first 10 days. And those patients with age over 75 years were more likely to develop hyponatremia than those with the younger age. So diuretic should be careful and used with caution and start with the lower dose. This is the detail of doses that they use in this study. They use thiazide about 35 milligram, furosemide about 47 milligram, and spironolactone about 71 milligram. But only 10 to 30% that use with or start with the lower dose. That's why they got hyponatremia and symptoms very often in this study. Other various complications that maybe happen or usually occur in elderly cirrhosis, including hepatic encephalopathy. In this issue, you must differentiate this complication encephalopathy from other causes such as from dementia or intracerebral hemorrhage. The ammonia level monitoring may be considered, but again, there is no strong data to support. Be aware the use of lactulose in this case of cirrhosis and advanced age because of the side effect. Volume depletion is the key. For pruritus and skin complication, you can consider to use some medication locally and some medication that less toxic such as antihistamine. For SCC surveillance is still important, even in advanced age with SCC. If your health, in general health, is still fine, the local therapy such as TACE or even molecular target therapy is still can be used, individualized, and regarding the cardiac and renal function that you need to monitor during the treatment course. And finally, you need to individualize therapeutic strategy for elderly patients because of the advanced age, the comorbidity. So you need to focus on patient-centered approach and considering their faculty. In summary, ladies and gentlemen, I emphasize on 5 issues that to be considered in advanced age or elderly cirrhosis. The first, management of complication. We be careful about the medication use. Nutritional support is the key. Faculty and function status is need to assess and address faculty. Polypharmacy and drug sensitivity is the key to consider. And finally, palliative care and co-care discussion with family or caregiver is important. Thank you.
Thank you, Dr. Sambat.
We move on to the next talk, and that's to be delivered by Dr. Dominique Vella, and he'll be talking about the ethical and moral dilemmas in management of end-stage liver disease.
Okay, great. Thank you. Okay, yes, perfect. So, thank you to Akash, Shukla and the organizing committee for inviting me to give this conference on an unusual topic for me. And so I have to make some disclosures. First of all, I have been educated and trained in France or Canada, and my whole professional life has been in France, and therefore I have a limited experience relevant to the Asian setting, first of all. Second, I have absolutely no training or formal experience in philosophy, ethics, or metaphysics, and therefore this topic will only aim to raise some questions which are personal questions that I would like to share with you. The three aspects among the many that are relevant to ethics and morals in the management of end-stage liver disease are the following three. I will touch on hepatic encephalopathy and mental capacity, the limited short-term and medium-term survival and what it implies for ethics, and of course, but very superficially, liver transplantation. So the liver doctor has to take information from the patient to explain him or her the diagnosis, the causes, the expected course, proposed investigation and therapy. And the liver patient has to understand, to retain the information, to weight it, to elaborate a decision, and to express a consent. And any impairment in one of these four aspects defines a lack of mental capacity. A lack of mental capacity is obvious in patients with overt encephalopathy. But the issue is a little bit more complicated with minimal hepatic encephalopathy. And you know that the prevalence of minimal hepatic encephalopathy is extremely high in patients with end-stage liver disease, over half of the patients. What we don't know exactly is the degree of impairment in mental capacity that is associated with minimal hepatic encephalopathy. But we know that minimal hepatic encephalopathy is affecting the capacity to drive one's car safely. So it could be that it is also impairing the capacity to drive one's own life, in other words, to make decisions. But if we, again, extrapolate what we know from the capacity to drive safely, we also know that minimal hepatic encephalopathy is only one factor which affects the driving capacity. And so for the mental capacity, minimal hepatic encephalopathy should also be considered in the context of emotional states, aging process, medical conditions, drugs, and so on. So in that complicated situation, the best help that I could find in preparing this talk was in the Mental Capacity Act from 2005 in the UK. This Mental Capacity Act states 5 principles, 4 of which are highly relevant to the patient with end-stage liver disease. The first one is that we have to presume that he is capable, a presumption of capacity. The second, that the patient has the right to be supported when making decisions. The third one, that an unwise decision cannot be seen as a wrong decision. And fourth, that the best interest of the patients, which are not those that the physicians decides, must be at the heart of all decision making. And then I believe that there are three main questions in the field of mental capacity in patients with end-stage liver disease. First of all, how can we assess the current mental capacity? Here we know, mainly from the studies on driving capacity, that the tests for M.I.C.E. or for cognition lack specificity. Very important thing. They are very sensitive, they are good to screen, but they are not good to state that there is mental incapacity. But the good practice of the General Medical Council, again in the UK, states that this is a part of core clinical skill to evaluate mental capacity without having the help or needing the help, for example, of a psychiatrist. And this is particularly true if we have done some way with the follow-up of the patient. Second point, what is the role of close family and relatives or friends? Certainly they can help and they will help for communication with the patient or for the identification of the best interest because they know patient's opinion, life, history, and so on. It's certainly very important, but it needs much caution. And this has been for me a painful experience of paying too much attention to what the family was thinking and which was not in adequation with what the patient was feeling. Moreover, the importance of family or relatives varies with cultures and with individuals, from fusional families to highly dysfunctioning families. And then what are the means for coping with impaired mental capacity? The first and most important thing to me is to help people make their own decision. And this is not simple. It takes time, it takes energy, it takes smartness. It costs money. The second means is to encourage the patients very early in the management to give a power of attorney to a person that will act as a healthcare agent for them. Third, to leave living wills and advance directives for medical decisions, again, very early in the course of the disease and its management. And when there is no other solution, to look for advocates, independent advocates for mental capacity that many institutions are able to provide. Let's turn now to the ethical issues associated with limited short-term and medium-term survival. This is an illustration of the very poor outcome of patients with with end-stage liver disease, taking ACLF here in the European definition as a marker for end-stage liver disease. You can see that the mortality approaches for 9 days 50% and is over 50% for 1 year mortality in most of these cases. Then in this setting of very severe disease, the main ethical notions I would like to discuss with you are need, utility, fertility, and survival benefit in relation to treatment. Treatment here being transplantation, resection, chemotherapy, admission to intensive care unit, any form of treatment. So let's take the example of a patient who before treatment has a survival probability of 25%. And the expected survival probability by applying the treatment is raised to 65%. This is a 40% survival benefit. Let's take now another patient with a baseline survival probability of 55%, which is raised with the intervention to 95%. Again, a 40% increase in the survival, a 40% benefit in survival. We will define the need by the expected probability before the treatment. And there is no absolute definition of the need. It's only a relative notion, the patient with a 25% probability being in more need than the patients with a 55% probability. And then there is the utility, which is the level of success that we can achieve with the treatment. And you can see that the patient in orange is in a situation of a better utility if the treatment is applied. The individuals, being the patient or the physicians, are always more keen to consider the need. But the institutions generally consider utility, institutions being government bodies, health insurance, hospitals, all these collective institutions. But what is really important at the level of the populations is the survival benefit. And you can see that here it's the same benefit for the two patients, about 40% benefit in survival. And this I would apply to two examples. The first one is the hepatic resection for hepatocellular carcinoma. It is well known that patients with a low portal pressure, HVPG less than 10 millimeter of mercury, have a better outcome than the patients with a higher hepatic venous pressure gradient. But we know also that this is true whatever is the case, not only for patients submitted to resection. There is a better survival in patients without clinically significant portal hypertension. And therefore, what we don't know is the survival probability in this study in the patients submitted to hepatic resection without hepatic resection. And it could be that resection, in both cases, provided the same survival advantage, although the utility will be lower in patients with pre-existent portal hypertension. The second example has been recently discussed very nicely in Journal of Hepatology. Should patients with acute and chronic liver failure grade 3 receive high priority for liver transplantation? We had a discussion on this earlier this morning. This study by Florent Artru, a multi-center study in Europe, has shown that in selected patients with ACLF3, the results of liver transplantation could be excellent, 83% survival, while the spontaneous survival in non-transplanted controls, matched controls, was only 8%. Actually, in patients with ACLF3, the survival in this survey was equivalent to that of patients without ACLF or with ACLF1 or 2. But we can go beyond that by using further prognostication. And on the right-hand panel, you can see the applications of the TAM score in patients undergoing liver transplantation. And they had, as you can see, being able to separate into four categories, one with a very low prognosis and one with a very good one. Meaning that in the left panel, the patients that had been enrolled in this study had been highly selected, and this is why they got a very good survival. Let's turn now to the last part of liver transplantation very briefly. Here, the issue is equity and justice. And to achieve this among patients with various severity, many liver transplant programs throughout the world have based the attribution of liver grafts on the priority based on sickest first. But there has also been an introduction of some element of utility. For example, the Milan criteria belong to the utility kind of criterion. But it could be also argued that what is important in survival, and indeed this is what has been implemented in the UK, following the study done on the population transplanted in 2013, when the system was not completely established. And you can see that compared, I don't know if I have an arrow. Well, the baseline was that 7% of the patients using the usual rules had died of being removed, and the total patient years gained with transplantation was 4,500. If they had modeled the attribution of the liver graft based on the need, they would have decreased the number of patients died or removed to 4% and increased patient years to over 5,000. Applying utility would have increased the number of patients died, but using the transplant benefit model would have both decreased the number of patients died to 4% and yielded a very high patient year achievement. The basis of liver transplantation in most of our countries is deceased donor. But due to the donation shortage, this has stimulated a tremendous development of living donor transplantation, particularly in India. But this living donor becomes a patient because he is subjected to right or life lobe hepatectomy with preservation of blood and biliary vessels, and then ethics applies to this patient. He was a subject, he is now a patient. And the ethics stipulate that there should be non-malfeasance, no harm, beneficence, respect of autonomy, and natural and distributive justice. And these are the main issues that are still raised, I think, and not solved completely with the living donor transplantation. There are many other issues in the ethics of liver transplantation. I've listed here selected readings which I found extremely interesting, particularly in the Indian setting. And to conclude, my personal questions are as follows. Regarding impaired mental capacity, how did I assess it? And what help did I provide to the patient and his family to make a decision? Did I encourage him to give advance directives? For the dismal outcome, did I distinguish need, futility, utility, and survival benefit? For liver transplantation, how did I increase the awareness and acceptation for donation, which is crucial to any kind of cadaveric or living donor transplantation? Did I provide fair information? Did I ensure full transparency? How did I stimulate the registries and prognostic studies that are indispensable if we want to solve the ethical issues? Thank you for your attention. I'm sorry for...
Thank you, Professor Vala. We're going to go to the last topic of this session, and it is management of morbidly obese advanced cirrhotics, the challenges and solutions by Dr. Puneet Puri. Dr. Puri.
So good morning. Thank you again, Akash, for giving me an easy, so-called easy topic where there are no guidelines. But thanks for this exercise. My next 20 minutes, I would like to highlight some of the perspectives where there are no clear guidance. And hopefully there will be some key take-home messages and good entertaining discussion. So the key concepts for today include how to recognize the impact of these two conditions. Independently, we know both obesity and cirrhosis do increase risk of death, but when they are present in combination, how does it impact? Also, direct impact of liver-related mortality because of the underlying condition we are discussing, and overall mortality that comes due to heart and cancers outside of the liver. And another important topic, which I'll touch only briefly, because this audience is pretty well versed now, but we can discuss as needed: sarcopenia, sarcopenic obesity, and frailty, how these can impact and interact with the condition of obesity. And lastly, what potential strategies can be used? Just want to give the importance that there are lack of data in this particular morbidly obese population, so we will use what is available in the literature. So looking at these two big problems, left side is your advanced cirrhosis, and the right side is morbidly obese. Most of the decisions what to do rely on whether this could be a patient who can end as potential liver transplant candidate, and if so, how can we optimize their chances of getting liver transplant? If not, what are our options? So this is clear that excess mortality is associated with excess body weight. There is, on an average, about 1,300 plus deaths that translate into about 500,000 deaths in a year in US due to excess body weight. And there is also overall increase in the mortality rates close to 20%, 1 out of 5 higher people dying due to obesity. And life expectancy on an average is decreased by 3 years compared to non-obese individuals. And this does not limit to just men or women. They are equally affected. So we have to pay attention to both cohort of patients. Also, in cirrhosis, as we see, there is a transition from compensation to decompensation or advanced disease, and there are many drivers, the two predominant ones being metabolic risks that also include independent effect of obesity as well as those with the insulin resistance. And this is further driven through increase in portal hypertension. So these are some of the key constructs where we will target in terms of how to intervene or how to recognize these interplaying obesity and portal hypertension related concepts. So this was a very remarkable study that came out from Dr. Bosch's group, Jaime Bosch, and this was demonstrating that obese patients have both higher proportion of as well as the probability of first clinical decompensation, as seen both on the left panel. About 42% patients with obesity have first episode of decompensation, and there's almost about 40% higher probability of having that first decompensation in obese compared to overweight or normal weight individuals. Now, what happens if these patients are followed over a period of a year? Those with normal BMI and overweight may improve in their portal gradients. However, this does not significantly change in those with obese. So this again highlights that the weight may have an important factor to play in the outcomes that may relate with portal hypertension. Now, I would like to highlight this technical important point that when we are measuring HVPG, there can be a difference based on etiology. While there is a high concordance on the control group on the right side of non-NASH related etiologies for the West hepatic and the portal pressures, this concordance is somewhat disturbed on the left side, which is of the NASH group. And this is due to, in this Bland-Altman plot, as you can see, there's greater than 10% variation on the NASH group side. With those subjects that are triangle, they are outside of the range. And this is the concordance is close to 86% in non-NASH cirrhosis patients compared to the NASH-related cirrhosis where the concordance is only about 62%. This is largely driven by the underestimation of the portal pressure, which is about 32% contribution to this discordance. So when we are measuring, BMI or obesity certainly has an impact on the accuracy of the portal gradients or the portal pressures that we are measuring. Also to highlight that with obesity and metabolic risk, majority of these patients have fatty liver or MASLD or NAFLD, which is a multi-system disease. So we don't have to ignore other aspects outside of the liver. And just to give an illustration as to what is the impact of liver-related or non-liver-related outcomes due to the presence of an age, this is a simulator that was developed, and that gives us an estimation of people likely to die or their 10-year survival. For a 50-year-old male, those that with cirrhosis, F4, nearly 50% will end up dying. Similarly, a 60-year-old male, the risk of death is 60%. So nearly about 15% higher risk of dying just due to age. And how does this impact? And this could be driven in a 50-year-old male, as shown with the broad red arrow, a cirrhotic. The likelihood of liver-related mortality is much higher relative to the non-liver-related mortality. And we must recognize we are seeing a lot of young cirrhotics, so this becomes important because these are potential candidates who could be transplanted or salvaged accordingly. But those that are older, like 60-year-old, the risk of dying, even with cirrhosis, is significantly higher due to non-liver related mortality that includes cardiovascular and extrahepatic cancers. So where we can make a difference, some solutions. Like our center, we studied this and we found that statin and aspirin appear to be safe in patients who are on transplant waiting list. However, these medications are significantly underutilized in the management of coronary artery disease. Close to about 1/3 of the patient had coronary artery disease based on angiogram as part of their prior cardiac evaluation for liver transplant. And liver statins were started only in 1/4. And this is coming for a liver heavy center like ours. Only 1/4 of the patients are on statins, while aspirin was used only in 1/3. So there is a significant opportunity to try to make a difference on cardiovascular outcomes. More concerning was that obstructive or multivessel coronary artery disease, statin use was only there in 41%, and just 2/3 of that patients were on aspirin. So there are some opportunities for us to get better. This study from the veterans cohort looked at the impact of statin and the survival. And clearly it shows that patients on the right side, those who were on the statins, had better survival, decreasing the risk of death by 28%. And interestingly, this was studied in 2 cohorts. One, those that patients were already on statins, and the other cohort where they were statin naive, and then they were initiated on therapy. So what is known is that statin naive patient, with every 10 milligram increase in cholesterol, the risk of death increased close to 4%. And that those with both existing users versus naive patients which were started on statin, both had about 8 to 10% decrease in their mortality. So another opportunity, that common belief that cirrhosis is a contraindication is not true. In fact, currently there are large trials through the Cirrhosis Network initiated through NIH. Now, what happens to patients that are listed for the transplant? Are they waiting for their liver to be transplanted? This study again came from our center combined with some other colleagues from outside of the US, and showed that patients in the UNOS database that were waiting for transplant, nearly 30,000 NASH patients, had with listing even with lower MELD score, less than 15, 15 to 20, and 21 to 30. As you can see, as the MELD score increases, other non-NASH related causes are the predominant contributor for the wait list or the transplant listing. What concerns is that the overall transplant probability while they are waiting for transplant is a lot lower, both at 3 months and at 12 months, nearly 15% lower chance that they will get a liver transplant. And this is more concerning when even with MELD score, which is greater than 30, that have higher risk of poor outcome, the hazards of or actually getting a transplant odds are 25 to 30% lower than those with non-NASH related etiology. On the right top box, which shows mortality, this is reflected as a result of their chances of getting transplant are lower related to other etiologies. As a result, both 3 and 12 months mortality increase risk of death from 15 to 25%. And as can be seen in this cohort while on the waiting list, both on the left, diabetic cohort, and those on the right with obesity, both situations, patients with NASH had significantly higher proportion, indicating that these patients should be prioritized early for interventions due to these metabolic conditions. Somewhat surprising, though, was that the risk of death was primarily driven by renal failure in NASH cohort compared to the non-NASH, and the non-NASH patients had higher risk of cardiovascular death in this particular observation cohort. What were some of the portal hypertension related complications? As we saw that the MELD score were lower for those listed with NASH in majority of those patients. There was no significant difference in ascites. However, these patients tended to get higher interventions with TIPS at 15 to 30 of their MELD score, as well as in all range of MELD score, there was higher risk of portal vein thrombosis. As another opportunity whether prophylactic anticoagulation, again debatable, is of value or not. Similarly, the distribution of hepatic encephalopathy was significantly higher in the MELD cohort across the lower spectrum of MELD less than 30, and the need for dialysis was significantly higher in those with MELD greater than 30, and potentially one of the reasons where we saw mortality was higher due to kidney failure. Now, what was happening to these patients while they were waiting on the transplant list? As can be seen on the left panel, all non-survivors had higher MELD score driven by creatinine, bilirubin, as well as INR. And again, as you can see on the right side, baseline MELD score was 18, and the MELD score for people non-surviving was just 24. So MELD score is not a good predictor, and these patients should be carefully observed and intervened, and allocation rules may need to be changed. Similarly, there was a higher overall mortality that I already showed before, from 15 to 25%, as predominantly in the lower MELD range. Now, what are some of the weight loss strategies for an obese cirrhotic? Like, this was the landmark trial that came, but was not typically seen in non-cirrhotic. This was a non-cirrhotic population primarily, but it showed that greater than 10% weight loss improved your fibrosis staging. Now, we have to take into account that not all cirrhotics are same, and they have to be accordingly educated where they merit best interventions. So pharmacotherapy for weight loss in cirrhosis and liver transplant, if you look at in the very right side of this, the Child-Pugh score C and potential transplant candidates, those are the ones with BMI greater than 40 that I just want to highlight, that these patients should be evaluated in according manner, and medication should be currently, for intervention should be currently withheld in prioritizing to get their liver transplant. Now, there is safety to the compensated cirrhotic. Two trials, one from Mayo Clinic from Kimberly Voigt, shows that intragastric balloon was safe and provided good weight loss. And this was also demonstrated by the Indian group from ILBS that showed that 56 of those cirrhotics, there was an average 15 to 16 kilogram weight loss with improvement in their HVPG, stiffness, and steatosis scores, and it was safe without any new decompensation or serious adverse event. Now, promising tools such as the endoscopic gastric plication are on the promise and on horizon. In this small study of 20 patients did demonstrate that it was safe and decreased portal gradients or HPPG improvement more than 20% of nearly about 4/5 of the patient. Lastly, the bariatric surgery group that does show that there is a significant improvement with weight loss, with the white column on the right showing that after 5 years, more than 50% regressed in their fibrosis. And this was just came out in Nature Medicine a week ago, suggesting that the liver outcomes were improved in those that underwent metabolic surgery. The top column showing the major adverse liver outcomes, and the right side showing that the compensation to decomposition events both were significantly reduced in those that underwent bariatric surgery. And similarly, long-term outcomes of patients undergoing simultaneous liver transplant and sleeve gastrectomy, one has to be very cautious. Very specialized skilled centers can perform this, where harm can also be done to the patient, so depends on the final. So I'll say with this that the misconception about obese patients that do poorly after liver transplant is not true. Similarly, obese patients should be, they are underserved and be recognized for listing and getting a liver transplant. And the weight loss prior to liver transplant is not associated with improved outcomes. Sarcopenia and frailty are more meaningful. And last part, I'll just show you, oops. So, exercise. So there are no trials that have really shown great results, except the largest exercise trial was the STRIVE trial, and then the FIT principle should be applied to use, which is frequency, intensity, which are critical to these patients, and the timing. Thank you for your attention.
Thank you, Dr. Puri. May I request all the speakers to come on the stage, please, for question answers? Kindly take your seat there, sir. Now the 3 talks are open for questions or comments from the house.
May I ask a question to Dr. Dominic Walla? Very interesting talk on ethics and mental capabilities. I wanted to ask you the relevance of resilience. There was a paper in Hepatology, and they developed a resilience score for patients with cirrhosis, the ability to fight. So what are your thoughts on resilience in a cirrhotic patient?
I'm sorry, Shiv, I didn't catch your question.
The question is the resilience score.
Resilience score. I don't know. It could be.
Okay.
I have no idea, but
Okay.
no data on that. But of course, yes, it should be very useful.
And one question is to Dr. Puneet Puri. The question is about the percentage weight loss. Normally we know for MAFLD that you lose 10% or 7% or so. But for a cirrhotic, obese cirrhotic, what should be the possible weight loss scenario to be able to reduce portal pressure?
So this is a great question. Thanks for asking. The answer to the exact percentage that will result into portal gradient change is not well studied. Even a modest weight loss of about 3 kilograms that was shown to improve portal gradient by about 12% decrease. Now, in your own study, while the weight percentage, absolute weight loss was closer to about 15 kilograms, and still then, in those patients, their HVPG gradient was decreased in about 11 to 12%. So there are no randomized trials to effectively study the role of like what percentage of weight change will translate to proportionate. It's not a linear relationship at best what we know.
just to give a feedback, the placement of intragastric balloon, which we published a few years ago, went to lose something like 12% weight. And it also reduced portal pressure. I don't remember how much, but in the obese cirrhotic, even in decompensated, I would say, and I would ask you and others, is placement of an intragastric balloon useful and can be tried?
The question, in my opinion, is like, what is the goal of an intragastric balloon? It depends on two things. One is your center limiting patients due to BMI. So BMI cutoffs in certain transplant centers is a criteria where their patients cannot get transplanted. So those that are compensated and safe, they can be evaluated first for liver transplant, be on the transplant waiting list, and can be considered to undergo weight loss procedures such as that. Currently, there are some non-invasive approaches which have not yet been studied in the randomized control trial fashion that could result greater weight loss. Now, whether that is something in the future worth investigating, because there is also concomitant risks such as GLP analogs that can cause muscle loss as well. So there is clearly data that low MELD score with sarcopenia can do poorly compared to even high MELD score with robustness. So one has to be very careful with the intervention, what it is aimed for. In our part of world, this is largely reserved for prioritizing their transplant and intervening accordingly.
Yeah.
Bariatric surgery has a lot of complications with these patients. So they've devised a laparoscopic gastric banding with adjustable bands for weight reduction. Your views on that?
So that's a good question again. Currently, laparoscopic gastric banding is not even used in USA. It's been considered unsafe as an overall procedure for weight loss compared to the current new metabolic surgical interventions, including endoscopic interventions and pharmacotherapy. This particularly can also impact patients' likelihood for laparoscopic or robotic surgeries. The transplant surgeons prefer not to.
Yeah.
Endoscopic sleeve gastroplasty? Endoscopic sleeve gastroplasty.
So again, this is a question that relates to the transplant or non-transplant situation, compensated to non-compensated. So because most of these procedures, when approved by the FDA, have a BMI cutoff limit. So in our center, we did intragastric balloon as a protocol for those that had BMI over 40 and did not want to get bariatric or weight loss surgery. And we found that there were 2 patients who could not tolerate out of 21 that we performed this procedure on. Everyone else was safe, no new decompensation. And 3 out of those patients now have maintained their weight loss greater than 15% with body mass or skeletal muscle mass preserved.
Yeah.
Colonel, please.
Puneet, excellent talk. I'm here, Anil Arora.
Thank you.
Yeah, my question is, the weight gain and the metabolic syndrome is the biggest culprit for producing everything, including diabetes, coronary artery disease, CV, and CLD. Biggest unmet need is the group of the patient who already have advanced cirrhosis. Child C, obviously, transplantation is the priority. So my question is, child A and B, every effort you make to lose weight will lead to weight loss both of fat as well as muscle. In fact, muscle is something which is giving you substantial advantage to carry on with whatever is left. So there is no way to lose weight without losing muscle. So any futuristic thoughts on adding drugs like glucagon or amylin antagonists, which preferentially tend to preserve weight of muscle vis-a-vis fat as a futuristic therapy, because that is the biggest unmet need. Because patient will come to you once you have jaundice, ascites. Otherwise, if they are fat or obese, they still are going on. So that big chunk of group still has a need for futuristic therapy.
So that's a very, very important point that you raised. Thank you again for your comments and insightful points that you raised. Number one, that particular cohort of child A and B what we now call as sarcopenic obesity. This is very common that they have relatively more excess weight relative to their skeletal muscle mass. And when they are trying to lose, the preservation of muscle becomes a challenge. In our own experience, what we have found is that we have dedicated kinesiotherapist available to reach out to these patients, but the adherence is very poor because almost 15 to 20% patient make it to finally work with a home-based or gym-based or any other exercise program due to a variety of reasons. And so the best way to try to motivate them is, like, now there are like resources available at least in certain centers like ours where they can have home-based exercise program developed with kinesiotherapists. They can work for 3 days a week. They have a schedule. So we have whatever we reviewed based on our measurements, which is bioelectrical impedance based rather than the other dedicated methods. We found that there is a better preservation of muscle mass relative to the loss in those that do not get. So from that particular standpoint, exercise is probably the best way. If they can do resistance training, that will further be more important.
And the least invasive technique of duodenal mucosal resurfacing, that should be safe. And I think maybe something which can be tried in subgroup of this patient, so that doesn't add up to any morbidity at least.
That's a great thought, and I think there are some trials that have demonstrated benefit primarily in controlling their metabolic risks, which are more like powerful outcomes than the weight loss, but a great option.
Regarding the sarcopenia, the protein intake is the most important in these patients, along with the exercises. And we use the growth hormone therapy for about a year, and the muscle mass was slightly better in those who were receiving the growth hormone therapy. And then regarding the management of elderly and the decompensation, the most important is the management of ascites in them. The moment we use the diuretics, they go into hyponatremia. And then the various problems arise, the encephalopathy worsens, and then many of these patients, they also have the renal dysfunction. So it's a complicated issue. We need to discuss it more since we are running short of time. Thank you very much. Thanks to all the speakers and the chairpersons. Thank you very much.
Thank you to the speakers and the chairpersons.